sometimes we're faced with patients who have got complex stones or complex anatomy. And normally in my practice, I would do a non-contrast CT KUB. But just sometimes it's very helpful to get a CT scan with contrast to help to delineate the anatomy, to help you plan and prepare for the correct approach to your case. So I think the case which I'm going to show you demonstrates that very nicely. But the case also demonstrates why it's good to have options available to treat the patient. If you've only got a standard PCNL, let's say a 30 French access that you use routinely, then that's not going to work for this particular case. And therefore, having another option, such as a miniaturized PCNL, I think is a nice thing to be able to offer patients. So this is a case of a 58-year-old lady who presented initially to colleagues with a left-sided loin pain. I'm going to take you through the CT scan now, and I want you to focus on the left kidney. And you can see in the left kidney there that we have an area of calcification just medially and in the interpolar area, which looks like some stone. So the plan for this lady was to have that stone managed ureteroscopically. And this is the retrograde pyelogram that you can see. And you can see here clearly the calyces. We've gone up with an access sheath there. And then having a look around all of the calyces with our ureteroscope, but unfortunately didn't find any stone within the kidney. The question of why we didn't find any stone wasn't clear. We thought possibly the stones were in a calyceal diverticulum, and therefore our plan was to arrange some more detailed imaging. The initial CT scan that we've seen is a non-contrast CT, but in this CT scan here you can see we've got some contrast, and then you can see the contrast is excreted into the collecting system. So you've actually got a delayed phase image here. And then you can see that as we go through this, you've then got this collection of stone here, or you can see there's a cavity there essentially, and that cavity is a calyceal diverticulum which has got the stones in. The other thing that you'll note as we go through this contrast CT is that we've actually got a duplex system. And you can see here that we've got two separate ureters. And so that maybe is the reason that we didn't see the calyceal diverticulum looking up retrogradely on the first time that this patient underwent surgery. Nice thing about these cases is it's a duplex all the way down to the bladder. You can get a very nice reconstructed model here, which shows in this coronal section the duplex system, but then also the area where you've got your stones in a calyceal diverticulum. And then you can see very nicely on this image here, which is this reconstructed image made by our interventional radiologist, you can see very clearly how tight that calyceal neck is, and you can see the cavity there that comes off the upper pole of this duplex kidney. And for me, looking at this, I would challenge anybody to think that they're going to get up to that upper pole through that very tight infundibulum and into this cavity to manage those ureteroscopically. So if this patient had a delayed phase contrast initially, I think that our initial plan wouldn't have been for her to have a ureteroscopy, it would have been for her to have a PCNL. Here on this endoscopic image at cystoscopy, you can see that we've got our retrograde catheter in the ureter, which is draining the upper pole. And then you can see just lateral to that, the ureteric orifice of the ureter that's draining the lower pole. And I think this was the ureteric orifice that was accessed at the first operation when ureteroscopic access to that diverticulum was achieved. So the next question then is, how are you going to manage these stones which are in a calyceal diverticulum? You can see the diverticulum is absolutely tiny, and our standard access of 26 or of 30 French, I would say is going to be too large to access that diverticulum. And that's where having maybe something like ultra mini or mini PCNL is a good option. You can see here that we've got needle access to our diverticulum, and we're then going to pass a wire, and we're going to dilate over into that. And then once we've done that, we can then pass our 13 French ultra mini kit over our access and then into the collecting system. So there we're just going in just with our catheter We've got access then through the top of the diverticulum, so you can think we're widening the neck of the diverticulum a bit there. And then you can see we've gone in with our ultra mini PCNL kit to access the diverticulum. And here we've got some video of what we actually find when we're inside this diverticulum. And you can see that instead of it being a single stone, what we've actually got is multiple small stones. And these are tiny stones which have accumulated because they're essentially in a big dilated cavity. They're moving around. They can't get out of that cavity because of the very narrow neck. And what we're able to do is just free them up from the blood clot that our dilatation has obviously caused. And then using the effect of the ultra mini PCNL and the Venturi effect, those fragments, those tiny little stones will then follow us out and be collected and sent off for analysis. So you can see there are multiple small stones, all of which I think are probably small enough to come out without using the laser. So there you can see we've got our retrograde catheter in, we've got our ultra mini access to the kidney. We've broken up the majority of the stone there. There are still a couple of tiny little fragments to remove. And that's just looking out of the neck of the diverticulum, trying to get out into the rest of the upper pole collecting system. You can see on the original dilatation, we've actually made that neck a little bit larger to hopefully improve drainage from this system. The important thing for this patient is going to be dietary and metabolic management afterwards to try and help prevent these stones from coming back, because the cavity is still present after this operation. So it's really going to be important that these stones go for analysis, that the patient has a full metabolic workup and lifestyle and dietary advice to try and prevent recurrence of these stones. I think that if you look at a non-contrast CT, if that's what you do routinely preoperatively, or if on whatever imaging you have got, things don't look quite right or look a little bit out of the ordinary and you're not sure, then think before you plan what you're going to do and get more detailed imaging, if possible, such as in this case, with a delayed phase to look at the anatomy of the collecting system. And that will then help you treat the patient in the right way first time around. That's the first message. The second message is to have options available for your patient. So if you think that an ultra mini or a mini PCNL is the right treatment option, then that's the thing that you should be able to use rather than just a standard PCNL if that's all you're comfortable using.